Hi, dear colleagues. My name is Marian Fanica. Welcome to the second day of the Aesthetic Marathon here in Poiana, Brașov. It's a high honor to have here with us Professor Dr. Ioannis Formousis. Welcome. You are from Greece. Your field of expertise is prevention, but you said you are doing also a lot of implants in the last time.
Yes, I'm actually a periodontist and an implantologist. So I do implants and perio and prosthetics.
I really enjoyed your presentation, but I still have some questions because here and now we are talking a lot about the restoration. We are talking a lot about aesthetic dentistry, but we are not talking that much about all that is prevention. Prevention in both children and also adults. Should we do more about this topic?
You know, 3,000 years ago, Hippocrates, that was the first doctor in the world, said that prevention is better than treating diseases. Yeah. And we have, he know that at that time. Nowadays, we should go for prevention instead of treating. Yeah. Unfortunately, we have more treatment and less prevention. Prevention means knowledge, and knowledge we have to the people before we get any prevention. So my personal opinion is that prevention is much more important than treating the diseases. We spend more of our time treating than doing prevention, but it should be the other way around.
When we are talking about prevention, mainly we are thinking about prevention in children, like fluoridization, like Pitt and Fisher sealant, but we are not thinking about that much about prevention in adults, which is really important. And this is a topic that should be taught. And my question will be, should we taught the prevention in school? The parents, for example, should teach the children what prevention is, or it's 100% dentist's responsibility?
Well, you know, knowledge is not one person's responsibility. The whole society should learn. So the parents should know how to do things in order to teach their children. The teachers have to know, so to transmit it during the school time. And of course, dentists have a big amount of work to show to people what they should do before having the disease, so that they could avoid the disease, either caries or periodontitis.
We are seeing today more and more implants placed, even by surgeons, even by general dentists. So that's why I think we are seeing a lot of cases of periimplantitis. From mild, I saw in your presentation, be just superficial, you can have also suppurating periimplantitis, which is really aggressive at that point. For me, that case will be almost hopeless. What will be your protocol for a mild periimplantitis, for example, superficial one?
Well, for superficial periimplantitis, it should be dealt with first with airflow, so that we take away in all our sittings, we take away the plaque or the biofilm. That's the first. Yeah. And then if the periimplantitis is still going on, we should nowadays use lasers. And with lasers, if the periimplantitis is mild, we can stop it. Yeah. If it's a really suppurating periimplantitis, then we can start with cleaning with airflow. If it is calculus, with piezo, and then with, like I said, with lasers. But then, after doing that 3 or 4 times, maybe we should intervene surgically. The surgical intervention, it depends from what we have in the area. But Usually most dentists, when they see a real established peri-implantitis, they just think it's hopeless and they just leave it like that. There is treatment for peri-implantitis. It's more difficult than it is periodontitis, to treat periodontitis, but still we can manage a lot of cases. And the sooner we do, the better, because if we do it early enough, then we don't have to do big things or even remove implants and remove bone and so on.
In your experience, there are the implants with the crown that are cemented on implants are more prone to peri-implantitis than the one that are screwed because of the excess cement? Or
well, I have been using for years cemented crowns, and I have seen some problems, not as many as the enemies of cemented crowns say, but if you can make good skeletons on your implants, it's better to have it screwed. If your technician or your abilities are not that good, then maybe doing cemented works helps you a bit with your incapability. Yeah.
Well, we were talking earlier before entering live about my frustration, my big frustration, because sometimes you have patient with really good hygiene and with periodontal pockets, with the disease that it's so aggressive with them, and I have no idea what to do with them. You try everything, the disease is still really aggressive. It happened also in your practice?
Of course. And this is one of the most difficult cases. In fact, we should treat peri-implantitis exactly as aggressive periodontitis. So each peri-implantitis is aggressive periodontitis. Even if the patient is not cleaning well, we should treat very aggressively. There are not new antibiotics, and we don't have many ways to treat aggressive periodontitis, but still, I find that is a big help from lasers. Since we use lasers, different lasers, we have a lot of better results with these patients. So we go with airflow, scaling, like we have been used to, and then we apply lasers. And then we can really change the microbiota. I am personally checking the microbiota after 3 or 4 lasers, and then I add, according to the result, I add another 3 or 4 sessions of lasers, so we can stop the disease. But these patients, because of their host response, they are very susceptible. So when they get stress or they get any problem in their life, they will go down again. So you have to have the best recall you can have for these patients. I try to keep it in 2 months. It's not every time possible, and after some months they try to avoid it, but still for these patients is the best they can do.
So in those cases, basically the balance between the immunitary response of the human body and the bacterial is not in the favor of the human organism. Basically, the bacterial much more aggressive that the organism can handle.
The host response is so soft and so slow and so minimal that even a little of bacteria or not so bad bacteria can harm these patients. So we can help these patients, and sometimes we can help them to bring up this host response with some additives like vitamin D or like fish oil, and they use it with aspirin. This make the inflammation go slower, and they don't have that much of disturbance in their mouth. So we can help a little bit the patient, and we reduce the bacteria as much as we can.
You talk about scaling, you talk about airflow, you talk about laser. Do we have some vaccines in the last period for this disease?
No, as far as I know, no. We don't have vaccines. And maybe for some years we will not have. If we have, that would be, everybody hope that we can have. If we have, that will be, I hope, the end of periodontitis. This is a goal for everybody, for every periodontist, but we don't have it up to now.
When we are talking about removing the biofilm and the plaque, who should take care of that? The general dentist or the periodontologist? Or should be, in the most difficult cases, should be referred to the periodontist, and the mild one, the general one, should be the general dentist?
I think prophylaxis protocols should be brought by the general dentist. And if they try with their best using what they have and they have no result, then it's the critical point to refer. Other cases, like very aggressive cases, they should be referred the first moment they see it. Because if they try, they just give time to the disease to go further. You cannot stop the disease, of the aggressive disease, by just scaling. There is no possibility. So you have to give this to the specialists. Actually, specialists exist only for these cases, because easy cases or normal cases of periodontitis should be treated by the general dentist. The rest goes to the specialist.
So the general dentist should know his limit, and he should know when to refer a case.
Yes, that's the optimal thing, to refer when they should do it. Doesn't happen all the time, but that's the optimum. It's not the job of periodontist to treat a gingivitis. This is a job for the general dentist, or even a simple chronic periodontitis. But when it comes to aggressive cases or very difficult teeth, then they should refer to periodontist.
Thank you for being with us here today. It was a high pleasure. I know that you have a flight to catch. That's why I, again, thank you. Thank you for your presence here.
Thank you very much, everybody. Thank you.
Have a good day. See you.
Thank you.
Bye-bye.